Second day of TANUVAS-GLOBAL Veterinary Imaging Sciences Webinar Series 2020. Yesterday webinar was on review of abdominal radiography in dogs and cats. There was a very active participation and interesting discussions was there. Today's topic is gastrointestinal ultrasonographic imaging in small animal practice. May I request respected and beloved Director of Clinics, Tamil Nadu Veterinary Animal Sciences University, Dr. S. Balasubramaniam, for the introduction on webinar.
A very warm good evening to one and all. As Director of Clinics and as Organizing Secretary of this TANUVAS Global Veterinary Imaging Sciences Webinar Series 2020, we have planned two topics. Yesterday we had a topic on radiography. The speaker was Dr. Natasha Moto from West Indies. So today, in continuation of the webinar series, we are having the topic on gastrointestinal ultrasonography in small animal practice by Dr. Laura Martinelli. See, just a brief introduction on the webinar. This Directorate of Clinics has been organizing series of webinar initially for the students of the constituent colleges of our university. So since this we have been doing since last July 2019, and this year in the month of August we started the first webinar under the Canine Research Center and Networks, first webinar for a global audience or participants. So the first one was on anemia and blood transfusion. So in continuation of that, we are having this webinar on imaging sciences. So this is again global. The number of participants, if you look into, yesterday we had around 1900 participants, and out of which 86 participants were from 17 countries other than India. So this is the reach of the webinar which is being organized by TANUVAS. In that context, so the TANUVAS is now connecting with one of the oldest schools in the world dedicated to the study of animal diseases, namely the Veterinary School, Italy, that was founded in 1791 and merged into the University of Milan in the year 1932. So I thank Dr. Laura Martinelli of University of Milan, Italy, for our webinar on gastrointestinal ultrasonography in small animal practice. So I am confident that this unique platform, TANUVAS Global Veterinary Imaging Sciences Webinar Series 2020, will impart quality online update on imaging sciences in ultrasonography in small animals to budding veterinarians, faculties, academicians, field and practicing veterinarians. So I request the participants to make use of this unique opportunity.
And the various webinars conducted by TANUVAS. Now may I call upon Professor P. Selvaraj, Department of Veterinary Clinical Medicine, to introduce the speaker.
Good evening and good day for all participants all over the globe. Good afternoon, Dr. Lara and Dr. David. Thank you so much for accepting our invitation. As our director, Dr. Balasubramaniam, said, we are very happy indeed to collaborate with you, one of the oldest universities dealing with the art of veterinary science in the entire globe. To the participants, I take privilege in introducing Dr. Lara Martini. Currently, she is working with the University of Milan and concentrating on the diagnostic imaging with special emphasis on ultrasound, diagnostic ultrasound and interventional ultrasound. And she was one of the very studious graduate during her graduation from the University of Milan, and she did some graduation thesis on low-field magnetic resonance. That itself shows her commitment to the field of imaging. And she has also interest in the field of alternative veterinary medicine, and she got an international certificate from International School of Veterinary Acupuncture in Belgium. A decade back, she obtained her master's degree in diagnostic imaging of dogs and cats from the University of Cambrino, Italy. And over the last decade, she is working specifically on the small animal clinical sciences, especially on the diagnostic imaging part. And her work also covers internal medicine and emergency medicine. Her current responsibilities in the University of Milan includes offering diagnostic and interventional ultrasound, with additional responsibilities in the field of radiology, magnetic imaging, and internal medicine. And her capabilities in ultrasound in the current work profile includes abdominal and thoracic ultrasound, musculoskeletal ultrasound, a thyroid ultrasound. Then she has a very unique capability in the ultrasound field in the area of ultrasound of skin swellings. That's a very, very emerging area where she is deploying ultrasound for the cutaneous masses. And she is into interventional procedures with ultrasound-guided fine needle aspirations and biopsies, and contrast ultrasound, and again a very advanced technique called elastomosonography. From her CV, we could able to identify that she is working on regenerative medicine field also, possibly for evaluating some of the stem cell treatment for the dogs and cats, like autologous stromal vascular function using the cells. Similarly, autologous mesenchymal stem cell therapies. And some of the papers were published in very reputed journals like Journal of Neuroinflammations. So both clinical and research, she is excellent, as well as in the field of diagnostic imaging. Dear participants, I present to you Dr. Lara Martinelli from Italy to the today's webinar. Over to Dr. Lara. You can go live.
Okay, so let's start again. Today we will talk about gastrointestinal ultrasonography in small animal practice. But before starting with this argument, let me show you some pictures of the university that the colleague presented.
Dr. Lara?
So, yes?
Some of your previous slides are not visible. Can you go from the beginning?
I am at the beginning.
Okay, then good.
This is the second slide. And okay, this is the faculty. We moved in Lodi since a couple of years in this beautiful new structure where students can study and work and prepare exams and take lessons for the theoretical part. Then we have a second structure, which is the hospital, which is this gray one, where we can have lessons with the animals, and we have visit rooms, the hospital pre-surgery room. This is where all animals are, we take care of them. This is the TC. As you can see, sometimes we do some strange animals. Like this white tiger. Then we have 4 surgery rooms for small animals and 2 for big animals. We have a low field MRI that we use for horses too, but also for small animals. And of course, ultrasonography. Let me thank Professor Davide Provettoni for these pictures, because he is our teacher for pediatrics, but he is also a great photographer. So let's start with the argument of the day. So gastrointestinal ultrasonography can give us a lot of information, but first of all, we have to choose the correct indication where to do it. And those are acute and chronic vomiting and chronic diarrhea. It is not so useful for cases of acute diarrhea, for example. What is really, really important in gastrointestinal examination is to pay attention to details, because they are very, very important. And it is always to correlate what we see to the clinical presentation and the clinical status of the animal. We have to start from the anatomy, because this is where everything starts. All the gastrointestinal tract has these layer structures. We should examine it always after fasting of the animal of at least 12 hours, because if there is food and gas inside, then our exam will be limited. If you remember the anatomy, the gastrointestinal is a tube. Okay, and in a section, we can see the lumen in the middle, the mucosa, the submucosa, the muscularis, and the serosa outside. As for the anatomic picture, we have a perfect image in ultrasound. Okay, this is a section on the long axis. Okay, so this is a sagittal scan of a part of the small bowel. In the middle, we have the lumen. It is this white line. Then we find the mucosa, the submucosa, the muscularis, and the serosa and subserosa. This is a normal appearance of the gastrointestinal tract. Every part of the gastrointestinal tract has its specific characteristics. For example, stomach is where I usually start to examine the gastrointestinal tract, and it has this typical appearance with rugal folds. Okay, the wall seems irregular, but it's because it's plicated, and if you see it, we can still recognize all the layers. Okay, from the lumen containing gas and sometimes food to the serosa, which is out here. Usually, the thickness of gastric wall goes from 2 to 5 millimeters in dogs and from 2 to 4 millimeters in cats. And it is very common to find food and gas in its lumen. It is moving, and we can be able to see the contractions that normally should be 4 to 5 per minute. Immediately after caudal, we find the pylorus. It is not always visible, especially in deep-chested dogs and in big dogs, but it's the transitional part between the stomach, that is this one here. You see it containing liquid and some material. And then we have this strange part where we do not recognize perfectly all the layers. Then they become visible, and we start with the duodenum. So this is the appearance of the pylorus. Usually in dogs it appears like this, but remember, it's not always visible. After that, we find the duodenum. We find it on the right side of the cranial part of the abdomen, and we see it as a thick linear part of the bowel that in dogs has a wall that goes from 3.8 to 4.4 millimeters, but in the cat it is 2.2 millimeters, so not so thicker than the other parts of the bowel. It is linear and superficial next to the kidney. Sometimes we can see the Peyer's patches that appear as small irregularities of the mucosa in its inner surface, like this, for example, with all the same distance, which are Peyer patches. It should be empty. When it's normal, it is generally empty. In the duodenum, we should always check the papilla, which is where the common bile duct gets in. Here we see the duodenum in a transverse scan. So this is the lumen, okay, and this is the wall. If you follow the wall, then you will see that here it seems that there's something crossing it. Okay, if we look in the video, which is easier to see, then we see that something is coming in. Okay, we can also follow it. So this is the common bile duct. In this case, it is very, very dilated. That's why we see it so well. And it contains also a bit of sludge, which is not normal, but we can see the papilla very well. We should be able to see it even if the common bile duct is not so dilated, of course, and it should always be examined. Going caudally, we find the jejunum. It is thinner than the duodenum, but it appears very similar, and it should always be empty. Sometimes we can see gas in it, but we should never have food in it in a correctly fastened patient. Afterwards, if we follow it, we can find the ileum. It is a very particular part because it has a prominent submucosa and muscularis that make it as all the layers were as thick as the others. Okay, it has this appearance of similarly thick layers. It is quite thick in dogs. In dogs, it is 3 to 3.5 millimeters, and not so thick in cats, but a little thicker than other parts. Also, this part should be empty in fastened patients. If we follow it, we get to the ileocecocolic junction. As the pylorus, it can be very challenging in dogs because gas and colon are containing, because cecum and colon are containing a lot of gas that can hide it. We have this typical appearance of three-way because we have the colon and then the cecum and the ileum all together. In the cats, it is a little different because it doesn't have this typical appearance. But as we can see in the video, we see this ileum with this strange wall getting in the colon that we can recognize because it contains feces and gas. Okay. As we said, this is the colon containing feces that have an acoustic shadow below and gas that has this gives us this typical artifact of comet tails. Its wall is very, very thin, which is this one, but we still can see the layers. We should follow it as much as we can, even if we have only a partial vision of it, because some pathologies can be visible also in the colon. So what do we have to remember before the gastrointestinal examination? First of all, to have the correct indication to perform an ultrasonography, to have the more information that we can. Then we should always prepare the patient that have to be fastened. And what we should never forget is that to be normal, we should always be able to see the layers. Okay, so given the part of normal and anatomy, let's start to talk about pathologies. Pathologies can lead to alterations of the motility of the lumen and of the wall, and all of them can be focal and can be diffuse and can be differently combined. First of all, we will talk about motility alterations. The bowel motility, as for the stomach motility, can be increased or can be decreased. In cases of increased peristalsis, we will see a lot of more movements. If you remember in the first slide, I said that stomach has 4 to 5 contractions per minute. If we see it continuously contracting, then we can subjectively say that the motility is increased. The bowel, when has an increased motility, appears very corrugated. We will see it later. When we have a decreased motility, which can be very dangerous, then we will see the hypoperistalsis until the paralytic ileus. As you know, paralytic ileus can be functional or mechanical, depending from the cause. But what we will see in ultrasound is this appearance. Okay. this central part of the bowel is much more dilated than the other parts. It contains fluid that goes on and back, okay, which a pendulous movement, and it means that the peristalsis is not moving caudally the food, okay? It's leading there and not going anywhere. So anytime we see this, then we should find the cause if we can see it, and we should try to identify if it's focal on a single part of the bowel or if it is diffused to the whole bowel. When we have different parts moving in different ways, it means when we have a part of the bowel which has increased motility and a part of the bowel that has decreased motility, one of the consequences of this dyskinesia is the intussusception. It can happen potentially in all segments, and we see it very typically. This is a cross-section, okay, on a short axis, and what we can see is that if this is the bowel, then we have a lot of walls and a lot of layers, okay? That's because we have one inner part of the bowel and one other part which is outside, okay? In the middle, we can find a lot of things. We can have the fat, the abdominal fat, we can find lymph nodes, we can find food, we can really find a lot of material. What is important is the appearance of one part of the bowel and outside the other. So we have the double wall sign. Ooh, can you still see my presentation?
No, somewhere
Are you still?
No, Laura.
Oh, it was closed by the computer. Probably too low. Sorry, let me try again. Okay.
Yeah.
Can you see it now?
Yeah, go with the
Yes.
Okay, sorry. Did you hear me, or
Yeah,
was it?
You
Yes.
need to go with the slideshow.
Yes, wait, because, okay, now it's working. Okay. So, as for the video, so there is an inner part and an outer part of the bowel. And inside, for example, here we have a small lymph node and a lot of fat. Okay, it can happen in every tract and in every animal. For example, in this case, the owner of this nice intussusception was the chimpanzee named Pina. So we saw the alterations of the motility. We can also have lumen alteration that can be, of course, associated to motility alterations, and that can be focal and diffused as for the motility. First of all, remember that the patient have to be fastened, because if we have food inside the gastrointestinal tract, then we can misinterpret the images because it can appear very strange. Let's look at this video where we can see a stomach which is very full of different things. We have some comet tail artifacts, we have some acoustic shadows, we have some objects inside. Okay, so this is a normal stomach full of food. This was just a dog that had eaten 5 minutes before the ultrasound. So it is normal to find gas, food, mucus, or compact feces that can be very tricky sometimes. What we can find sometimes, it is not so common, but it can happen, is that if they're very big, we can also see parasites. As in this case, okay, do you recognize the bowel here? Okay, it is a straight part with its wall. Sometimes it is moving, we see some contractions. And if we look at the layers, so this is the lumen, this is the lumen, this is the mucosa, the submucosa, the muscularis, and the serosa. Inside we have these two nice tubular structures that cross one on each other, that are where ascaris in a cat. Not always we can see them so well, but if they're very big and if we're lucky, then sometimes we can really recognize them. One of the most common indications of gastrointestinal ultrasonography is the search for foreign bodies, which is one of the most difficult things, in my opinion, because they're all different shaped. They are all made by different materials, and they all have different behaviors. What we should look for is the foreign body itself, but we have to be able to recognize if we have some complication due to the presence of foreign bodies, as for example the occlusion or the perforation of the bowel. In this video here, we will see an occlusive foreign body. Okay, you see the bowel. Here we have a transverse section. Here we have a sagittal section. If we follow it, we get to this object that has a very strong acoustic shadow below it, and the part of the bowel cranially to it, which is here on the right side, is full of material. The wall appears a little thickened, and the layers are less visible than normal, and around it, sorry about the video stopped, let me go back to it.
There is another voice in the background.
There is nobody talking
here. There is an echo of your same voice. I don't know.
Sorry, but there is nobody talking.
It's like a registration is going on with you talking.
Should I stop?
I don't know what's happening. Maybe you can go on.
Okay. In this case, we also see a very hyperechoic peritoneum around them. So this is an occlusive foreign body because the transit is completely obstructed, but we can also suspect a perforation because there is no free fluid, so maybe it's just a small perforation, but there is peritonitis all around the bowel. So anytime we see a foreign body, let's look for perforation because we have to decide if we should perform a medical treatment or a surgical treatment. What is even more challenging, if possible, are linear foreign bodies because when an animal eats a wire, its behavior is that it gets stuck in a place. It gets tensed with the movement of the bowel trying to push them out, and it cuts. Little by little, it cuts the wall. In this case that we see here, it was a young cat that was playing with a wire, and he decided to eat it. So what we see here, this white structure, tent and linear, is the linear foreign body. All around it, the bowel is plicating to try to push it, but it was stuck under the tongue in this case, and it was reaching till the jejunum, so it was impossible to push it away. Even in this case, we see the peritoneum mildly hyperechoic, so even if there is no free fluid in the abdomen, we should even consider that it cut the intestinal wall. So we should also tell the surgeon to look for eventual perforations. As I said before, when there is an increased peristalsis, we will have corrugation of the bowel. I waited to talk to you about this because we have to pay very attention distinguishing the corrugation from the plication. The corrugation is a symmetrical undulation of the wall with the serosa remaining relatively linear. As for in this case, let's go from inside. Okay, this is the lumen. Then we have this nicely undulated mucosa. Then we have the submucosa, the muscularis, and the serosa, which remains relatively linear. Okay, this is the previous case of the foreign body. So we see the linear foreign body in the middle. Okay, and this is the wall. Okay, the serosa out here is very, very plicated. Okay, so differently from this one. In this case, we should suspect, or maybe sometimes we can see a linear foreign body, and in this case, we should suspect, for example, an inflammation or an increased peristalsis or whatever can gives us this hesitate to this corrugated aspect of the bowel. So, about lumen alteration, what should we remember? First of all, fast the patients because food can have a really tricky appearance. Remember that sometimes we can see parasites, so they're not foreign bodies. And remember that we should look for the foreign bodies, but also for them, their complications. Okay. Last part of our alterations are the alterations of the wall. This is where we should really pay a lot of attention to details and where we can have a lot of information about, for example, chronic cases. What can we see on the wall? Sometimes we have one layer that gets a lot thicker, like for example, in this case, if you see, this is the stomach. It is containing a lot of mucus. We do not see the rugal folds anymore. Okay, the wall is almost tensed, and we can still recognize the layer, but one of those is very thick. Okay, so if we count from inside, we have the lumen, the mucosa, the submucosa, which is this thick one, and the muscularis, and outside the serosa. So this is the appearance of a gastric edema that involves the submucosa and that hesitates in a hypoperistalsis of the stomach. So we can also have one more layer. For example, in this case, if you look at this image and if we count the layers from inside, so the central one should be this one. So mucosa, submucosa, which one? Muscularis and serosa. Okay, in this case, we can see one more layer. In the middle of the mucosa, we have this linear band, which is called linear mucosal band, that should indicate a fibrosis, and that may or may not be associated with concurrent inflammatory conditions. Usually when we see it, we can talk about, for example, chronic enteropathy that has still to be defined with a histology of the bowel. In this case, we can also see that there is an increased thickening of the muscular wall. Even if we have the linear mucosal band, then the black muscularis is very, very prominent in all the parts that we can examine. Okay, so we have a lot of layers and a prominent one. In these cases, it can be due to the eosinophilic enteritis in cats or the IBD, but we can see it also in mechanical obstructions. If you remember the foreign body that we saw before, the wall was very a little thickened and hypoechoic. But it can also be due to neoplastic infiltration. For example, in cats with this bowel presentation, we should always consider lymphoma, even if it's not our only differential diagnosis. We can have small lines also transverse to the sagittal section of the mucosa. Okay, this is a duodenum. It is a more or less straight superficial part of the bowel. We have the lumen inside here. It is mildly dilated and containing fluid. And going from inside, we find the mucosa, which is not so hypoechoic as it should be, the submucosa, the muscularis, and outside the serosa. The mucosa is not so hypoechoic because it has all these transverse hyperechoic stripes that indicate the dilated lacteals. So in cases like this, our first diagnosis should be lymphangiectasia, especially if we have, for example, dogs with chronic diarrhea with steatosis feces and, for example, with a chronic loss of weight. We can also have focal lesions of the wall. For example, in this case, you can recognize the stomach. It has these nice rugal folds, and the layers are always visible, but here we have a focal round-shaped lesion, hypoechoic, in the thickness of the wall, and we cannot see exactly which layer it involves, but our differential diagnosis can be a polyp or a granuloma or a neoplasia. Anyway, this is an indication for endoscopy or for surgery, depending how it grows, whether towards inside or outside. If we have a complete loss of layering, then we have a big problem because probably we are dealing with a neoplastic infiltration. How do they appear? So if you follow this central part of the bowel, then you can see that the wall, it's very strange. Sorry, the video is not going as so. Let's start again. Okay, so concentrate on this part. We start with a normal bowel, then we have a neoformation, then we have a round alteration of the wall, then it gets normal, then we lose the layers again and it normalizes again. We can see also a small amount of free fluid next to this part. And the problem here is that we really do not recognize the layers anymore. We just see the lumen and we just see the serosa, and inside we do not see anything anymore. Okay? Here it's all one layer. If you see down here, then we will see some big round-shaped structures, which are the mesenteric lymph nodes. So anytime we see a loss of layering, we should suspect neoplasia. And for this, we should always check the lymph nodes. So what about wall alterations should we remember? We can have a thickening of a single layer, like, for example, the gastric edema or the thickening of the muscular layer. We can have the linear mucosal band that appears as one more layer. We can see these transverse hyperechoic lines that are the dilated lacteals, or we can have a complete loss of layering in the worst cases, where we should always suspect neoplasia. So what to do if we are dealing with a suspect of neoplasia? This, for example, was a very severe case. Here we see a normal part of the bowel. In a transverse scan, we can recognize the lumen, mucosa, submucosa, muscularis, and serosa. But here we can see the sagittal scan. Okay, this is the lumen inside. We have the wall very, very, very thick. We do not see any layer inside. Okay, and if we look at it in the video, we can notice that also the motility is reduced. Okay, the food is going on and going back. Okay, so anytime we have a neoplasia, we will have a loss of layering, motility disturbance, probably lymph node involvement, so increase volume and different shapes of the lymph nodes. And we should check as for the foreign bodies for complications, because also neoplasias as foreign body can lead to an occlusion or a perforation. So we should check if transit is maintained or if we have peritoneal hyperechogenicity or free fluid in the abdomen. Anytime we have a case as the one we saw before, then we should think about taking a sample. First step, which is the fine needle aspiration. It is usually performed with a 20 or 22 gauge needle, but also the second step, a true cut biopsy. Usually it is performed with an 18 gauge true cut, and it is generally a safe procedure. What we should do is, of course, to avoid the lumen, and what is limiting us is that we will never have an entire wall biopsy. We can also only take the more external parts. Anytime we see a lymphadenopathy associated with associated to a lesion that we suspect to be neoplastic, it is always recommended to take samples also of the lymph nodes. What I usually do is, first of all, surgically prepare the patients. So we have to cut the hair and clip, and after proceed with a surgical scrub. And then I usually prefer to have the screen in front of my face because I can be more precise when I get in with the needle. This was a fine needle aspiration of colon focal lesion. The dog was sedated because the lesion was very small. So I get in with the needle. I get in plane. I could also go extra plane on the other side of the probe, but I prefer to go where I can see my needle. Then I get inside the lesion and I move the needle and I aspirate a little. When we finish taking samples, then we get in and we immediately put the sample on the glasses. What we will see is, for example, this is a transverse scan, okay? This is the part of the bowel with the very thickened wall. This is the lumen. Inside we have a few gas and little content, liquid content. Then this is a round shape alteration that involves the whole wall of this part of the bowel. And here it is thicker than the other parts. So I decided to get in here. So this is the tip of my needle. Okay, I'm coming from this side. I go in the lesion. I avoid to stay close to the lumen. Even with my angle, it shouldn't be as safe as this in this case to get from here, because if I do not see perfectly the tip of the needle, I could go inside the lumen, and I move in and out, and I aspirate in the mean. Anyway, we have the lymphadenopathy, remember, to take sample also of the lymph nodes. For example, these are the mesenteric lymph nodes with a cat with intestinal lymphoma. In this case, we took samples also of the lymph nodes. This is my needle, okay? This is the tip of my needle, getting inside the lymph node, moving and aspirating, okay? So we get in, we look for the tip of the needle, and then when we see perfectly the tip of the needle, we get in and out to take samples. If the animal undergoes a surgical procedure to remove a part of the bowel, for example, the dog of the first fine needle aspiration that you saw had a carcinoma that was focal on just one part of the bowel, and he went to surgery, and the surgeons removed a part of the bowel. So they did an enterectomy. They removed, as in this image here, they removed the pathological part and they did anastomosis of the residual parts. We should always control after surgery, after enterectomies, because ultrasound can give us a lot of information. What we will normally see is the wire, the surgical wire that appears as this white part with acoustic shadow, okay? And what we have to control is that there is transit. So we should never find occlusion signs as, for example, one part more dilated than the other, or if there is peritonitis or a free fluid localized next to the surgical site. Okay, so this is a normal appearance of post-enterectomy control. Okay, so to end our lessons of today, remember that any pathologic condition of the bowel can lead to alterations of the wall, of the lumen, of the motility, and most of the time different combinations of them. What we have to recognize is the layers and check the lymph nodes, and if we can, always take samples. Thank you for your attention.
Thank you very much. And if you can forward me the question, I can ask and I can forward them to Laura as well.
All right, there are some about the interactions are there. We limit some of the interactions. Maybe the first interaction is about how to differentiate intersusception from prolapsing. Intersusception from prolapsing.
I can. It's better if you can send me the text because I can't see. There is a lot of a delay between what we say and what we hear.
Yeah, Dr. I'll just ask, how do you use ultrasound to differentiate intersusception from prolapse of the intestines?
Well, when you have a prolapse, then the intestine is outside, okay, goes outside from the rectum, and it goes out. So the diagnosis of prolapse is clinical. When we have the intersusception, then we have occlusive or subocclusive symptom, clinical presentation, and if you look at the image, you have one part of the bowel instead the other one, but it's all inside the abdomen. There is nothing prolapsing out. Okay.
Yeah, can you go back to your presentation on the intersusception part?
Yes.
And show me the slides, the intersusception slides.
Okay, let me go back. You're not able to see my screen, right?
Not yet.
Can you see it now?
Yeah.
Okay. Okay, so in this case, we have the inner part of the bowel, the mesenteric fat, okay, also a small lymph node, and the outer part of the bowel. So if we have one part of the bowel moving slowly and one part of the bowel moving a lot, then it will go up one on the other, and we will have one bowel inside and one part of the bowel outside. So if we look at the transverse scan, we will have a double layer sign as in this case. But with the prolapse, usually the prolapse is the same part of the bowel getting in the wrong direction. So it will prolapse and go out of the body. So we will see it outside, but it's just one part of the bowel. Here we have two parts, one moving slowly, one moving faster, and that get one on the other. So the echographic sign is this double wall. So one wall inside and one wall outside.
Thank you. Second one, how to identify blood clots if there is a peritonitis.
Sorry, I don't hear you.
Identifying blood clots.
Blood clots? Okay. They appear as new formation without correlation to any organ. They are usually hypoechoic. They have different shapes because they're not rounded, or they are all different. And with the color Doppler, we can see that there is no blood flow in them. So if we have a clinical appearance of the patient, a clinical presentation of the patient, that can make us suspect of bleeding, and we see structures like this, then we can suspect that they are clots.
Next one, if there is adhesions, how do you identify using ultrasound?
If there is what, sorry?
Adhesions, fibrous adhesions.
Okay. Sometimes we do not see them. We cannot clearly identify them. We can see that the complication that they lead to, because sometimes they can provoke volvolus or or obstruction of parts of the bowel. So maybe we cannot see those, but we can see the complication that they lead to most of the times.
Okay. In case, if there is a rupture of intestine, can you use your ultrasound to identify that?
Yes, of course. Well, if there is a big rupture, then we will have free fluid. We can take sample and see that is in gastrointestinal content. Or if there is small rupture, then we can see maybe a focal peritonitis or a focal adhesion of the omentus to the bowel.
Okay. Then there is one more person asking, is there a possibility to identify pyloric outflow using ultrasound?
Pyloric outflow?
Yeah. Can you monitor pyloric outflow?
Well, pylorus is not always so well visible. So ultrasound would not be my first choice. But we can see if, for example, there is a hypertrophy or retarded gastric empty, or if there is some mechanical obstruction.
All right. There is one question which was not related to GI, but can you use ultrasound to evaluate lymph nodes, especially to characterize lymphoma? Canine lymphoma.
Can you see me again?
Yeah, I'm able to see you. Do you able to hear me?
Yes, now
okay.
yes.
Yeah. Can you use ultrasound to assess the lymph nodes, especially to characterize canine lymphoma?
Well, yes. Yes and no. So we can see the lymph nodes that have some characteristics that can suggest us that there is lymphoma. But the diagnosis never only by ultrasound, okay? We have always to take samples. For example, lymph nodes with a lymphoma appear more round-shaped, hypoechoic, with increased volume, but we can just say that we can suspect a lymphoma with ultrasound. If we want to make the diagnosis, then we have to take a sample.
Yeah, thank you, Lara. Lara, can you do one thing? Can you close your PowerPoint so that Your interaction could be better. Close your PowerPoint screen sharing.
Okay.
You need to stop the sharing.
Okay, I stopped.
Yeah. Now there is almost like many people have asked one common question: how do you got such a good quality images?
Well, these images are of a brand new Zaote machine, so in this case, we really have a big advantage. But the key is the preparation of the abdomen. So always fast the patients, always clip hairs, always use. For example, the gel and sometimes also alcohol to prepare the skin. And not always we can get these images. Most of the times, it depends from the animal itself.
Okay. Again, in the same line, there are some more questions, like which probe will be better, which frequency of the probe will be better to assess the GI?
Okay. It depends from the size of the animal. Because of course the probe and the frequency is related to the dimension of the objects we are looking at and the how deep they are in the abdomen. The ideal probe to examine the gastrointestinal tract is the linear probe because it is usually a high frequency probe What we look for in this case are the details. So the higher frequency that we can use in relation to the dimension of the animal, the better will be the exam.
All right. Again, possibly there is one more question. In the market, there are many machines available. Which sort of machine will be better to capture images like what you presented? That's what several people had asked.
Well, I always worked with Zaote, so I really have good images, and I would not change. But well, there are many types of machines. It depends on how one is used to. But well, these are all images by taken with Zaote machines.
Okay, and I would add that I work in Zaote, as I think you suppose, and I would like to add that we do not take human system and we say that now our veterinary, but we develop our system in a veterinary field. So we work with KOLs, key opinion leaders like Laura Martinelli, like the University of Milan and many others to develop the system and to get a system which is able to reach high diagnostic standard in vet. So we ask to the vet what they want, their questions, their desires, and we try to create the best system possible with a vet-oriented workflow. So not only the probe for vet, but also the report, the measurements. We have, for example, a very advanced cardio package with all the new vet measurements according to the new guidelines. And that's very important because we want to enhance the vet experience and the diagnosis of our customers.
Yeah, in the same question, somebody asked, which model you recommend for small animal practitioners?
I would say that it depends.
Many people asked which is the one you recommend.
Yeah. It depends on the needs you have. For example, if you are a freelance and you work a lot on the field, a portable system is the best choice. Is portable, ergonomic, with a big screen, and you can use it everywhere. And on the other way, in a clinic, we have also many card-based systems. We have the new one like the MyLab X8 and MyLab X7 that are very, very good. And if we talk about portable system, MyLab Omega and MyLab Sigma are the best choice because they are very light, just 5 kilos, and you can bring them everywhere and do your exams, as Laura, I think, can confirm.
Yes.
Thank you. One of the questions is, how to identify a necrosed intestinal segment?
Well, a necrotic intestinal segment sometimes is very hard to identify. because usually these parts have a thicker wall with hypoechoic. Sometimes they are hypoechoic. It depends from the congestion, or sometimes they are much more similar to the edema. But usually they are dilated. They're not moving, and they usually have the omentus hyperechoic next to them. So anytime we see a part of the bowel like this, then we should suspect a necrotic part, but we can never be completely sure about it.
All right. How to identify intra-abdominal hemorrhage?
Intra-abdominal hemorrhage, usually it is there is a free fluid that it's very corpusculated, and depending from how much there is, it is easier to identify. Of course, if we have a lot of fluid and we can take sample and see that it's blood, then this is the easier part. Sometimes we can see a controlled hemorrhage, a self-limiting hemorrhage, so maybe we can find the clot, stick to the organ, and maybe some focal free fluid, and the omentus always trying to stop the hemorrhage, so stick in, so hyperechoic, as for the necrotic parts, for example.
Okay, probably the last question I would like to put. In many cases, there is a foreign bodies in the GI system. Sometimes it could be plastic foreign bodies, sometimes it could be metallic foreign bodies. Is there any possibility to identify and locate either it's a plastic or metallic ones?
Foreign bodies are very, very challenging. For metallic foreign bodies, usually we start with an X-ray, and then we try to find it secondary with the ultrasound, so that we maybe can identify if there is some complication or some problem related to it. With plastic foreign bodies, sometimes they are really invisible. So if they are giving complications, then we see the complications, and then we suspect maybe a plastic foreign body. Or sometimes they are so big that we can see them, but foreign bodies usually are very, very challenging. In my experience, they're one of the most difficult things to identify with ultrasound.
Thank you. Coming to the closing part of the webinar, I thank both of you. That was an excellent presentation and excellent.
Thank you.
Gracie, now I call Dr. Vijay Kumar to offer the closing remarks.
Thank you for your invitation. Thank you.
Thank you, Lara and David. That's a good presentation, and we thank Selvaraj for acting as a moderator to reduce. There are about 375 questions. You cut shorted and then made it to a nice interaction. And now may I call upon Dr. Arun Prasad, Professor Ned, Resident Veterinary Service Section, for proposing vote of thanks.
A very good evening, good afternoon, and good morning to all. Confidence and hard work are the key to success. So it's my pleasure to propose the vote of thanks. On behalf of the organizing committee, TANUVAS-GLOBAL Veterinary Imaging Series 2020, Directorate of Clinics, TANUVAS Chennai, we express our gratitude to our Honorable Vice Chancellor who had permitted us to conduct this webinar on Global Veterinary Imaging Series. We extend our sincere thanks to the international speakers, Dr. Natasha Muttu, University of West Indies, Trinidad and Tobago, on review on abdominal radiography in dogs and cats, and our esteemed speaker, Dr. Laura Martinelli, University of Milan, on gastrointestinal ultrasonography in small animal practice, for sparing their valuable time and for their excellent presentation. Thank you.
Thank you for your invitation.
Dr. David also had been helping us. Thank you. I thank our director, Dr. S. Balasubramanian, Director of Clinics, TANUVAS Organizing Secretary, who is the man behind this successful conduct of this program. I thank you, sir. I thank our Dean, MSc, Head of the Clinics, Dr. L. Nagarajan, Dr. Krishna Kumar, Head of Gynecology and Obstetrics, MVC Chennai, Dr. Vijay Kumar, Peripheral Hospital, Dr. Selvaraj, Professor Clinical Medicine, who had supported in organizing the event. We thank our faculties, staff of the clinical department, clinical administrative staffs for helping us in administrative activities. We express our thanks to the Department of Extension Education for providing us audiovisual aid and conference hall. Thank our bioengineering section for providing uninterrupted power supply. We extend our gratitude to Mr. Karnanidhi, Senior Vice President, and Santosh, Dr. Santosh, our information technology partner, Alembic Pharmaceutical Limited, for the successful conduct of this webinar. Not but not least, I thank and appreciate all the faculty members, undergraduate and postgraduate students, field and practicing veterinarians from all over the world for their active participation and successful conduct of this webinar. Thank you, one and all.